Hello everyone, thank you for joining us again. We're here at Research Works podcast at EACD at the pre-conference workshop in Melbourne. And as you can see right next to me is Professor Iona Novak. Thank you so much for being here, Iona.
Thank you for having me. It's fun. We're Australians and I'm seeing you in Germany.
I know, right? I do find that really bizarre. A lot of people who I think I would see more often in our home country, we never see each other on our own land. We've got to travel overseas for that. Well, today is all about this big pre-conference workshop about early intervention. And of course, you are part of all of that too. And I saw the title of your presentation, Traffic Lights. It's what you're really well known for amongst many other things. But before we get into the nitty-gritty of stuff, what is it that lights your fire? Like, what is it that really motivates you to do all the kind of work that you do?
I am so motivated by children having dignity and having choice. And they're the only patient group that don't get to decide what they do. And so my life's work has really been about listening deeply to children and finding things that matter to them, that motivate them, excite them, and really make positive changes for the sort of change that they want.
That's really beautiful. And what do you feel like you are, out of all the work you've done, that you're most proud of? Is there such thing? Is there something that you feel like you've gone, yeah? Does that exist?
That's a tough question. You know, what really excites me is when a child says, I did it myself.
Beautiful.
That actually is what motivates me. I mean, I trained in rehabilitation and I really don't want the credit for it. It's not about me. I really love it when a child actually gets to own the moment and has that sort of sense of self-agency.
Yeah, that's beautiful. And I would say what you said to both myself and Ash all the way back in season 1, that we bring up all the time is whose brain is doing the work.
Yeah.
And we've used that many times. We always credit you for it, of course, but it is something that we think about a lot because for some reason, through training, through therapy, what we see therapy as is always us doing something to another person. Yet when you learn a new skill, like, I don't know, gymnastics, learning how to play tennis, no one's handling you in that kind of way. No. I feel like for you, how you've described how people learn and then you just saying, I did it myself, that's pretty powerful. Yeah. So the traffic light system, every time I see traffic lights now, I do think about you and your team, which is really bizarre. And everyone talks about the bubbles and, you know, what it all means. That's come a long way this last, is it nearly a decade now?
Yeah.
Can you talk us through a bit of the progression, the journey? I guess we want to land back to where we are now, but how did that progress over the last 10 years?
Yeah, so it's been a great journey. I mean, it was a simple idea really to give a common language. You know, I went to work one day and my favourite manager, who was a social worker and these huge ethics that I deeply respected, had to make a cut in a service, and she announced it, you know, with a great sense of compassion and sadness. But I was also intellectually curious about like, why did you cut that and not that, and realised we didn't have a common language. And that's where it came from. And also in Australia, with new funding for families to buy their own services, there's a vulnerability when you want the best for your child about what you buy, and you're so influenced by what people tell you. So to give the language to families about choosing what would work, because every family wants something that works. That's really where it came from. And I think we've seen this extraordinary shift in, you know, 10 or 12 years in the evidence space. And one of the biggest ones is early intervention, which is why we're here in Germany today to talk about that. But that's exciting, right?
It really is. And it's amazing. It must have been so beautiful to be in that room where you were looking at, you know, what's looking like it's working, what's looking like it's not working, and going, oh, there's common threads in this. Yeah. That must have been really fun.
Yeah, absolutely. When you have that aha moment, you know, there is a lot of joy to that, isn't there? And it's amazing to see just how many people are contributing and what we're learning from each other as an international community. And when I say community, I mean people with cerebral palsy, their families as active members. We're learning so much with them and from them and together with them.
For sure. And as amazing as we have as a beautiful visual of the traffic light system, have you encountered or have you heard people talk about, you know, it not being relevant for them, or they don't want to use it, and like what kind of reasons they might have for that?
Yeah, I think there may be as many people that hate it as love it, but that's okay. You know, the major criticisms have been, you know, it's too simple, is something I hear. And in fact, the back end is very, very complicated, but the front end is deliberately simple to give a common language. You know, I hear people say, well, it's not relevant in my context, and context is incredibly important for any intervention. First, you've got to listen to the person and what matters to them and their life, and then the context of the health system. So that is a real scenario. The one I don't like is Novak said, because it's actually it's not me. It's just a summary of what we're all saying, right? And I don't sort of weigh in. It's not personal to me. I think I wear a patient hat at points in my life, and so I have this objectivity about trying to cut through the noise of things to see what is giving us a trend to what might work, what might not be the best use of our time. And that's where it comes from for me. So even though it feels personal to some people, it's not personal to me. It's just a plain summary, and hopefully we can move forward together.
Yeah, I really like that, because I think over time, as you've seen more things being added and you see, you know, what colours they might be, you do see those common trends. So if something new pops up, you can pretty quickly think, okay, what's the motor learning theory behind it? What's the basis that it might be on? And then you can make a bit of a decision from there and look further. So it's a great common language. So now that we're moving into the more early intervention space, what have been the new developments there when it comes to the traffic lights?
Yeah, I think this is one of the exploding parts of the field. In the last 10 years, we've seen extraordinary change. So today I sort of talked about what I called early intervention 1.0. When we first published the traffic lights, there was a single bubble for early intervention. It was yellow.
Do you remember that?
And somebody very famous in the field, and I'll leave their name out, said to me, were you crazy, or did you know what you were doing? And I paused. I said, both. And why did it get that rating at 2013? Well, it was because there were only 10 randomized controlled trials about early intervention.
Really?
8 of them showed no benefit. Only 2 had a benefit. 8 out of 10 actually had a passive motor approach. 2 had an active motor approach. And so we looked at that 1 in there with the big effect size, and it was active motor. And we thought there's some clues. And so we wanted to move on quickly from early intervention 1.0.
Yeah.
And in 2016, I sort of announced, I think we're going towards early intervention 2.0. And that was because we recognized that we could now make an early detection or an early diagnosis of cerebral palsy. So first thing we could do was change the timing. So even though we call it early intervention, it's really late intervention.
That's right.
Until very recently.
Yeah,
and we were also concerned about the content of that intervention, so passive versus active, whose brain's doing the work, back to that concept.
Yeah, beautiful.
We were concerned about the dose. So we were looking in Australia, and that adult stroke guidelines said a patient should have 14 hours of rehabilitation in the first fortnight after their stroke.
Wow.
And that was the exact same number a baby with cerebral palsy was getting in the first year.
Wow.
And we were like, how does this happen? We all believe in early neuroplasticity, early treatment. So we were worried about dose as well. And I was also worried about specificity. So if I thought about 4 5-year-olds, one with Down syndrome, one with spinal muscular atrophy, one with cerebral palsy, one with an intellectual disability, their rehabilitation at 5 would look really different.
Yeah.
So why was it vanilla? In infancy, everybody got the same thing.
Interesting.
And could we do better at predicting what might change for the baby? What might be their areas of strength that we could celebrate? Were there areas that might be hard for them and we could lean into those and practice them and do a good job? So that's the sort of thing we were thinking about after 2016. So we wrote that early diagnosis guideline in 2017. In 2022, we had an early intervention guideline, 21, led by Dr. Kathy Morgan and a big team there as well. And we moved forward from there. And today I'm saying I think we're at early intervention 3.0, which is cool. So coming to where these traffic lights have updated, at 2020, we're starting to see this separation. So we're starting to see small yellow bubbles rising towards green for task-specific, goal-based intensive training. We were starting to see things that were coaching alone were sitting next to the worth line. So they gave some benefit, but not a lot.
Okay.
It just wasn't quite enough. And we were starting to see passive motor fall below the line. And I think, you know, we're going to update the traffic lights later this year, but I did it specifically for today for this conference. And what we see now is there's this very clear separation.
Wow.
So there's bigger green bubbles in early intervention. They include task-specific training.
Good.
They include goal-based interventions. They include coaching-based interventions coupled with those. So very similar to what we saw in later childhood, but we see the same pattern happening in early childhood. It's just that the therapist has to have greater creativity.
Yeah.
I don't have many Australian babies that respond to you. You'll do 50 repetitions of that exercise.
I don't know one, but someone tell me if they do find one.
Exactly. So that idea of being very creative to entice a child to want to play and make those repetitions, something that's fun for them.
Yeah.
And then we're starting to see some emergent new early interventions, so some work in early feeding, borrowing these same motor principles, but in learning to swallow and manage your food safely. That's
Huge
really
gap in that
nice
area
work.
to this point.
That's been like a black hole in the middle of the traffic light, if I can put a fourth colour in there. And so that's exciting, and we're starting to see things about dose. So we've got data now that timing makes a difference. Children that receive intervention before 6 months do better. We've got data about the type of intervention. So we're starting to see this clear separation. Not only have we got green bubbles up the top for task practice, we've also got a red bubble for passive motor. So it's this clear separation. It's exactly what we saw with children and with adults as well.
Very
so it's not surprising, but we now have data.
Yeah, that's brilliant. And is there much that we know about the actual dosage, like in terms of how much is needed?
Yeah, it's a great question. We can start to see in the early studies in this 3.0 that dose clearly makes a difference. And then we've had it's a great problem, but we've got a problem. First of all, we had a COVID pandemic, which sort of wrecks any clinical trials. So a few of us still had some wrecked clinical trials. But we also found amazing great therapists in the community increase the dose. And so usual care in 2025 doesn't look the same as it did in 2013, right? It's not passive anymore, it's active. It's not low dose, it's higher dose. So it's really hard to get these comparison points now. But there is some work in baby habiteel showing a high intensity was helpful for children, but we also have to balance this with babies do best when they sleep.
That's right.
They do best when they eat.
So the families. They all do.
So you've got to manage a life and a moment for a baby and a family as well.
That's why number can be so dangerous,
exactly,
because it can just steer someone in a direction you do at the cost of all else, but we know it needs to be really balanced. What about, was there anything that surprised you? I mean, all of the things we've heard so far have been pretty consistent. Like, is there anything that kind of comes from left field? Does that exist?
Well, you know, the findings in rehabilitation have been consistent. I think the one people are going to get a spook factor is that we put a green bubble for early intervention for having stem cell treatment. So that really is going to throw people, because a lot of people would say the phrase, we're not there yet, or, you know, it's too experimental. But in fact, there's great data now in cerebral palsy in children under 5 to show it improves movement skills.
See, now that is amazing, because you're absolutely right. For some reason, there has been this perception that it's still on its way, yet the last we spoke, there's been a lot of work done. In fact, you did a meta-analysis. You don't do a meta-analysis unless there's a lot of work being done. I did see recently this amazing media release about stem cells, Cerebral Palsy Alliance being a really huge part of it. So this is where we're at the moment. Can you talk us through what that's all about?
Yeah. I'd like to title this article, "It Took 15 Years and a Village."
That's probably the best article title,
And when I think this through, you know, we talk about a gap in practice taking 20 years to close, right? And which is more than a childhood. This is work in the last 15 years. There's been extraordinary progress. We've come from the bench to small animal to large animal through to clinical trial, and now over 800 children with cerebral palsy have been treated in clinical trials. And and it's thousands in off-label private clinics as well. But we were recently able to meta-analyse, not just study to study, so mean to mean, we were able to analyse at an individual participant level. So this work was led by Dr. Megan Finch-Edmondson. And by pooling all this work and collaborating with authors, we were able to not only confirm, number one, umbilical cord blood stem cells are safe for children with cerebral palsy categorically, which confirms what we saw in the, in the bone marrow kind of literature and other things in blood cancers. That they are effective and they improve gross motor skills. So the first thing somebody might want to ask me is, well, by how much?
That's usually the next question.
Yeah, exactly. So actually the effect sizes we're seeing from a single dose of umbilical cord are almost twice the known effect sizes of rehabilitation and orthopedic surgery, which are the two main sorts of interventions. And an individual patient meta-analysis also lets you look at responders who, so every parent asks, would my child benefit from this? And we always want to answer that question with as much precision and kindness as we can. So we found three things as well. Children under 5 are the best responders. So younger is better, not a surprise. Again, we're here at an early intervention conference, but it is consistent with what we would think about neuroplasticity because stem cells do make new circuits, and by practicing and using those circuits, you retain and strengthen those circuits. So it makes a lot of sense. The second thing we saw was that children with a milder physical disability, so GMFCS 1 to 3, so can walk or predicted to be able to walk if they were younger, they respond better. And again, we were looking at gross motor skills, so that doesn't surprise me either. Children that can learn to move, something that assists movement, will make it work even better. So we see that pattern as well. And we also saw a dose response curve. So every umbilical cord's unique. It's got a unique set of blood. Unlike a medication, you can't really control the dose. It's what's in the cord is in the cord, right? So we looked backwards at doses, and we were able to see really clear threshold cutoff. So children that got over 50 million cells per kilo of body weight had a response, and up over 70 was better. And this is exciting too for families because the field, of course, started in a conservative way with low doses because we were thinking about safety at the same time. But as we've seen the safety profile confirmed, the doses have gone up, and we haven't really reached the maximum dose possible. So I think we can go higher and maintain that safety profile. So I think there's more we might even see from this product. But I imagine some of your listeners might say, well, is she left her rehab roots? Is she saying cells, not rehab? Actually, I'm saying both.
I love how you can foresee all the questions that are coming. Yes, that was going to be the next one. Does that mean I'm out of a job?
No, definitely not. Cells, umbilical cord is good at stimulating natural healing processes in the brain. And one of those is to elicit new circuits, make more circulation and blood flow to those. But who is the best people at strengthening those? Well, it's children when they do lots of repetitions, but it's therapists who set up scaffolds and work with parents and scaffold at the just right challenge, the practice of those circuits. And that's how you get it from a gravel driveway like here in Germany through to like those autobahns, right? Onto that freeway system. And so it is going to be a combined therapy. It's not a either or, it's not a competition. I think we've seen this in the field before with orthopedic surgery having a good result when it's paired with rehabilitation. We've seen it with botulinum toxin.
Yeah, that's right. They go together. It's very inspiring to think about what the next frontier might be. And I imagine this would mean we need to think about things differently in a whole new area of research in terms of outcomes from interventions, and which is a really exciting place to be. In terms of its availability now, is it now readily available? Like what should we be saying to our families who are eagerly waiting? Well,
I think you could say it's evidence-based umbilical cord blood now. We could say it's safe and it does improve movement. I think the challenge here is it has a higher bar because it's a biological product over rehabilitation as a regulatory approval, or it has a higher bar even over surgery probably and pharmaceuticals because biologics are still in their infancy everywhere. So It is not approved in any country in the world. It is close to approval in the United States. The FDA have been working very closely with, you know, esteemed colleagues at Duke University looking at that issue. I think it's imminent. And certainly in Australia, you referred to a case recently we off-labelled first child in Australia not in a clinical trial to receive their own cells back as a treatment.
So
and so we're
very
close and
yeah.
we're working really hard with politicians, and it's actually, I do a lot of knowledge translation work, like what would change people's behaviour, but this is a really different thing. There's fears about cells, there's rules that are archaic, so cord blood belongs to mothers legally. Cord blood belongs to people with blood cancer, but it was donated by Australians for Australians. So could we get the rule expanded?
Wow. So,
so this kind of knowledge translation work with policymakers and thinking through these issues is complex, but the product is there. The product is safe and offers benefit.
That's very exciting, Iona. That's beautiful how you placed all of that within the traffic light system as well, to see where things are looking at. Now for therapists, for researchers who are listening to this right now, do you have one main thing that you want people to take away from what you'll be presenting here in Heidelberg? Is there anything that you have in mind?
Well,
a lot of
we've all believed that early is better, but in fact we didn't know what to do. We didn't know how much of it to do, and we weren't really doing it early before, but everything has changed. We can now give a really early timing of intervention, and earlier is better. We know which type works, so these task-based, goal-based approaches work, whereas the passive motive approaches don't work. We're still learning about dose. More is better, but there is probably an optimum amount, and too much might not be a good thing. So we actually have to really respect children and parents with that. And then actually being really specific. So predicting what is the prognosis, what is the trajectory for this child, and actually leaning into their strengths and leaning into some things that are hard for them. So I think the future is really bright.
It's really exciting. I'm glad I'm in this area. It is really wonderful, and I love how when you spoke about that as well, I remember you spoke last time about the grey area of harm, and it's always about that balance, isn't it, in terms of like how much is too much and what we could be providing. So that's that for me as a clinician is always really vital. Thank you so much for the work you've been doing, for sharing with us today at this conference, on the podcast. It's always just so incredible to think how much the field has been moving forward in the last decade. And I remember that first traffic light publication, it was a call to action, and it was answered in the most amazing way. So thank you so much to all of our listeners. I hope you enjoyed that as much as I did. I had to keep my hands very still so it didn't look like I was too excited by every single thing that Iona was talking about. But please stay tuned for so much more. We'll put links up for all the things we're talking about as well. So thank you so much, and thank you, Iona.
Thank you.
Thank you. Bye.